Okay, thank you. Thank you for your kind words. And thank you for being here today. Also, I would like to extend my thanks for the organizing committee inviting me for this very important meeting. Actually, I'm not anymore chairman of hematology oncology now because Dr. Aida Al-Awadi now she is the one. Until last month, I was the chairman of hematology oncology, just to correct this data. So today I will try over the next 20 minutes to cover with you multiple myeloma, and I'll try to highlight the very important points about diagnosis, treatment, and the changes that happened recently. So indeed, these are the topics I will try to cover in next 20 minutes. So multiple myeloma, I think everybody hear about it or know about it. So it is a cancer of the bone marrow, mainly on the plasma cells. And in the normal situation, actually, plasma cell produce immunoglobulin, different type of immunoglobulin, and this immunoglobulin help us fighting the different type of bugs try to make us sick. So, but in multiple myeloma, actually, these cells will produce ineffective immunoglobulin, and only one type, usually either the IgG or part of the IgG. As we know, the IgG there is heavy chain and light chain. So the multiple myeloma either producing the whole immunoglobulin or just part of it, what we call it light chain. So the origin of B cell, of plasma cell, it is B cell, but maturated to be a plasma cell producing these antibodies. And regarding the incidence or prevalence of multiple myeloma, actually last year they reported 35,000 plus cases in the United States. And usually the median age is about 69 to 70 years. And the relative survival is about 60%. So the epidemiology of the multiple myeloma, actually it consists 1% of all cancer, human cancer, 10% of hematologic malignancies. It is more in the elderly, but it can happen in any age. But usually the median age, as I mentioned, is about 70 years. But in United Arab Emirates, as all of you know, that the cancer age is little bit younger. Maybe there's so many reasons. So usually it's 65 years, the median age for multiple myeloma in UAE population, and that's because of population demographics, plus genetic factors and environmental factors. The multiple myeloma tend to be slightly more in the male rather than female, and it's more in African American. And the risk factor, actually, there is no fixed risk factor, but whenever any family member has multiple myeloma, the rest of the family are at higher risk. Also, exposure to some radiation or some chemicals can increase the incidence of multiple myeloma. So pathophysiology, actually, it is simple because the multiple myeloma started from the bone marrow, and also it affect the bone itself. So it's normally the bone marrow will not function as usual. So then we will have some cytopenia, anemia. And also this cell is producing abnormal proteins. Usually this affects a vital organ like kidney, especially the free light chain can participate in the renal tubules and cause renal failure. Also, the normal plasma cell will not be able to produce enough immunoglobulin, then the risk of infection will be significantly increased. So the clinical presentation, actually, as we said, it is the bone disease or bone marrow disease. The patient will come with bone pain, and sometimes the patient can present with catastrophic fracture, or sometimes they can have cord compression and paraplegia. So most of the patients, they present with fatigue and hypercalcemia symptoms, renal dysfunction, as we mentioned, and infections. So what we do whenever we work up a patient with multiple myeloma or we suspect multiple myeloma, actually there is a general testing. As you know, we do CBC and full chemistry, but there is specific test we do it for multiple myeloma patient, which is serum protein electrophoresis, urine protein electrophoresis, free light chain, it's very important. And also we have to calculate the percentage of plasma cell in the bone marrow because it is diagnostic, as we will see in the next slide. So, and also all patients with multiple myeloma need bone marrow. As you know, if there is some other hematologic disease nowadays, we don't need to do bone marrow like CLL. We can diagnose it by peripheral flow cytometry. But for multiple myeloma, bone marrow is essential. And we have to look in the bone marrow for FISH, which is fluorescent in situ hybridization, just to see if there is any translocation between different chromosome, or what we call it fusion genes. And also have to do conventional cytogenetics, clonal plasma cell percentage. And regarding radiology, in the past, actually, we exposed this patient to many X-rays. We do simple X-ray for the skull, for the spine, for the extremities. Nowadays, no, we don't do this anymore. Just we use a whole body low dose CT scan. And also PET CT scan can play an increasing role, but it is not for all the patient. And MRI also, if in case of the whole body CT scan didn't show a lytic lesion, we do MRI for the patient just to see any lytic lesion, and we will see this later on in diagnostic criteria. So indeed, multiple myeloma is part of plasma cell dyscrasia scope. Plasma cell has multiple disease, or we can say all the patients started from monoclonal gammopathy of unknown significant to smoldering myeloma and active myeloma. So what is the differences between this different type of disease? Actually, the first two, it is asymptomatic. The patient has nothing. You don't feel anything wrong with him. For the third one, most of the patient, they have some symptoms. So the differences between the monoclonal gammopathy of unknown significance and smoldering myeloma, it is mainly the amount of paraprotein in the serum and the bone marrow plasma cells. So in this case, here the M component is more than 3 grams and plasma cell between 10 to 60%. But here it is less than 3 grams, and usually it is less than 10%. That's why the bone marrow is very important, and it's crucial to differentiate, is it MGUS or smoldering myeloma, or it is active myeloma. And this MGUS, maybe the patient will survive normally for 30 years without anything, but usually 1 to 10% of them, they can progress to multiple myeloma. So regarding criteria, in the past we have this, we call it a CRAB. And now they added the CRAB Slim. So for the medical student and for the resident, they easily can remember this CRAB Slim. So CRAB, actually, it is C for calcium, R for renal failure or renal impairment, and A for anemia, and B for bone lesions. So this is CRAB. Regarding SLIM, this is recently added to the diagnostic criteria. So the S is for 60. If there is more than 60% plasma cell per se, without anything else, we say this patient has active multiple myeloma. And LI, it is light chain. So if the light chain percentage between kappa and lambda, it's exceeding 20 times. So either kappa is 20 times more than lambda, or lambda is 20 times more than kappa. So this is per se, it is active myeloma, and the M is for MRI. So in case if the whole CT scan is negative and we did an MRI and we found a small lesion in any bone, so this is a criteria. So please always remember CRAB, SLIM, it's easy even for your exams. Regarding risk stratification, actually, there is international scoring system, and recently they revised it. They added some factors to this system. So actually, it's mainly based on the beta-2 microglobulin. You can see here if it is more than less than 3.5 or more than 3.5 plus normal albumin. So we can say this is low risk, high risk, intermediate risk. Recently, they added high risk cytogenetics here, and the serum LDH. So, and this is reflected here. You can see the patient with low risk, actually, they have normal life. The overall survival is normal. The patient with intermediate, they live usually 83 months, and the high risk, it's half of the intermediate, only 43 months. So there was a debate. So regarding, since these patients are asymptomatic, why to treat them? So I would like to go with you now, why to treat and why not to treat. Actually, the guys who said why to treat, they said the patient has no symptoms. Why to give him acetotoxic medication which make him sick? So this is it's rational. And also they say there is no evidence that the treatment will increase the patient's survival. On other side, actually, we have seen this in our practice. Sometimes the patient come with renal shutdown with very high level of free light chain, requiring renal replacement therapy. And sometimes the patient come with pathologic fracture affecting his health, and they can be paraplegic. And nowadays, we have very effective treatment with less side effect. And also we have the trials, so we can enroll these patients in the trial and see. And I will show you now the evidence that why to treat some of these patients. So they actually segregated these patients to two groups. High-risk group, they benefit from treatment, and low-risk group, they didn't benefit from treatment. So you can see here actually the patient with high risk, most of them within the first 2 years, it's half of them, they will progress to active multiple myeloma. So why to wait until the patient progress to active multiple myeloma and he come with renal failure or pathologic fracture or something else? But on other side, the low-risk patient, only 5% of them will come with active multiple myeloma, and that's why we are not treating these patients. So now we have this, they call it 20-20 models, and it's very easy to remember. So in case of the M components is more than 2 grams, in case of the plasma cell and the bone marrow exceeding 20%, and if the ratio between kappa and lambda is 20 times, this is a high-risk patient. If it is less, that means no need to treatment. So it is 2 grams, 20% plasma cell and more, and 20% kappa lambda ratio or lambda kappa ratio, treat. Less than this, you don't need to treat. So what do we have? What's our tools to treat multiple myeloma? Actually, there is many medication classes. We can choose out of them. So this is immunomodulatory, this is proteasome inhibitors, here is the steroids, monoclonal antibodies, and the new medications, CAR-T, PITE. So I need you to remember, especially the student, the first 3. Always there is a steroid, either dexamethasone or prednisolone. So dexamethasone always there. Any protocol you will see D. Either big D, that means 40 milligrams, or small d, that means 10 or 20 milligrams. Then we take one of these things, either IMIDs or proteasome inhibitors, usually first generation, second generation, third generation. Most of the time we go with the first generation, so we select one drug from this class, another one, plus dexamethasone as front line treatment. Plus there is bone modifying agent, we have to take care of the bone, and also antiviral, acyclovir, valsaclovir, and palliative care and symptomatic therapy for the patient symptom. So selecting treatment for multiple myeloma is general principle. There is patient factors, disease factor, treatment regimen. So we have to take the patient age, comorbidities, and regarding the disease, is it high-risk disease with high-risk cytogenetics, or it's no standard risk, treatment toxicity, if the patient has cardiotoxicity, if he has high risk of thrombosis, if he has active infection, or as we saw in the previous lecture, if he has latent TB or something. So all of these things has to be taken in consideration before we decide what treatment we will select. And in general regimens, they tried doublet, triplet, or quadruple. So for sure, no doublet if the patient is fit. So always we use 3 drugs. And recently, there is more increasing evidence that 4 drugs is better than 3 drugs. Actually, we divided the patient regarding the fitness for stem cell transplantation, because if we can transplant, we have to transplant all the patient, but some patients are not fit. So we can say stem cell transplant fit patient, we give them 4 cycles, we harvest, we collect the cells, then we give 2 more, or sometimes we proceed with autologous stem cell transplantation. After that, we give 2. Then there is at least 2 years maintenance therapy with single or double agent chemotherapy. For the patient who are ineligible, actually, we have to treat them continuously until either the disease progress or the patient has unaccepted adverse events. So now the summary of initial treatment for younger patient fit for multiple myeloma is 3 to 4 drugs. VRD is the very common, so the Velcade, Revlimid, and small d, as I told you, this 20 milligrams of steroid. Then proceed with autologous stem cell transplantation. Then maintenance, high-risk patient, we give them 2 drugs, like proteasome plus lenalidomide, and for the standard risk, only 1 drug, which is lenalidomide. So first-line multiple treatment, adverse, actually, in general, there is some class effects. So all proteasome inhibitors, it's neurotoxic. So we have to take care of neuropathy and tingling sensation for the patient. We ask him, we assess him every time. Immunomodulatory, actually, is bone marrow suppression, plus it is thrombogenic. So the patient has high risk of thrombosis, so that's why we always use either low-dose aspirin or sometimes anticoagulation, regardless, NOAC or low-weight molecular weight heparin. Monoclonal, it is allergic, mainly bronchial spasm. So the problem with multiple myeloma, it is a relapsing disease. It is an incurable disease, but it is treatable disease. As diabetes mellitus, it's incurable, but it's treatable. Hypertension, it is incurable, but it's treatable. In the past, usually the patient survived maximum 3 years. Nowadays, the patient survived 20 years, and some of them, they are exceeding 20 years. So the issues with multiple myeloma, always relapsing. So usually the patient started with MGUS, monoclonal gammopathy of unknown significant, then he will progress to active multiple myeloma. He will receive, as we mentioned before, the treatment, 3 drugs, then for sure maintenance therapy for 2 years, usually within 4 years, 5 years, maximum 7 years, the patient will come back. He will have relapse. We have to also here treat him with the relapse, either we use the same treatment, or if he progresses on the lenalidomide, we don't use lenalidomide. Then usually the duration of response after the first relapse, it is shorter, until we come here, there is no treatment. So here there is unmet need for multiple myeloma. Until maybe 2-3 years back, we have nothing. Just we send the patient for palliative care physician and symptomatic treatment. Regarding how we monitor these patients, actually the patient has to come every month or every 3 months. We do the paraprotein and the routine labs for them. And in case of any suspicion, we do the images which we have discussed before. So regarding the selection of treatment, as I told you, there is something disease-related, therapy-related, and patient-related, and I think we discussed this slide. And for the sake of the time, we'll go to the second slide. So choosing therapy for patient with relapsed refractory. So the new thing that we are adding the monoclonal, which is daratumumab, and we go with the second generation or third generation. As I show you, we have different classes and we have the generations. So we always go to the second or third generation when we are selecting the treatment for the relapsed case. Here is the precise medicine. Actually, everybody is talking about precise medicine or the targeted therapy for cancer, and you hear about targets. So actually, always the hematologist, oncologist try to find a fixed target on these cells. Usually, it is receptors on the surface of the cells. So in multiple myeloma, usually the BMCA, which is the B cell maturation antigen, it is fixed even in the relapsed disease. So they try to target this BCMA by different way. So I'll show you. Here we talk about the thrombotic events, and we have to cover this thrombosis infection. I think it's covered in the previous lecture. And the bone health, always we use either bisphosphonate or denosumab for the multiple myeloma patient. So I would go directly to the BCMA because it's very important. So this is the BCMA, and it is presented in all multiple myeloma in different stages. Either it's a front line or if it's in the relapse. So it is fixed markers. So what happened here? They either they do the antibody drug conjugate, so they give specific antibodies which is targeting BCMA, and they put here the cytotoxic medicine. They call it drug conjugate, and so whenever Can we go back? Just 2 slides, I'm almost done. No, next slide. Okay, so this is the drug conjugate. Actually, the other one, we call it BITE therapy. Also, this is monoclonal antibodies with CD3. Usually, it's attached to the T cell, cytotoxic T cell. The other one is to BCMA, bring the policeman to the thief all together, and they will come. The last one is the CAR-T. We take this cytotoxic cell outside of the patient body. We engineer it through a vector virus. We put a virus, and then this T cell will be able to recognize the cancer cell. And this is live medicine. You infuse it again, it will produce daughter cells. This daughter cell also able to recognize this cancer cell and kill it. They call it CAR-T cells. So the patient is sleeping, is walking, is in the market, at home. So he has somebody is working in his body fighting the cancer. So it's amazing, actually. And here is the unmet need I showed you when we have multiple relapses, or we call it pentarefractory. That means the patient is refractory to all type of treatment, myeloma treatment. We use CAR-T. And I have a patient, she started with me to 2008 with multiple myeloma, and she had 2 bone marrow transplantation. She is pentarefractory. I just recently sent her maybe 3 months back to United States of America, where she had a commercial CAR-T. She came back with 0 disease, nothing, no M protein, no plasma cell, no lytic lesion, and she is normal, almost as if she is cured with this CAR-T. So there is some miracles in medicine, and as if the time progress, also our tools against this cancer is progressing. So with this, I would like to conclude that multiple myeloma is a plasma cell malignancy with significant impact on bone and kidney and overall health. Current therapies combination target therapy 3 to 4 drugs. Diagnosis CRAB slim. You need to remember this criteria: serum protein electrophoresis, urine protein electrophoresis, bone marrow biopsy, and unlisted CT is very important. Prognosis improved with recent advancement, but high variable depending on the risk factors. As I mentioned, multiple myeloma is treatable but incurable, but I hope in future it would be curable, and the CAR-T and the BITE, which I just briefly explained to you, has a hope in the future. Thank you very much.